The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good evening, and welcome to this webinar on the use of bone markers in osteoporosis therapy monitoring. I'm Dominique Pierrot, Science Manager at IOF, and I will be your moderator. Before introducing the speaker of the day, I would like to inform you that attendees are automatically muted during the webinar. I also would like to encourage you to ask questions during the webinar by typing your questions in the question box on the GoToWebinar control panel. I will voice your question to the speaker towards the end of this webinar. And now I'm happy to introduce our speaker, Professor Richard Eastell from the UK. Dr. Eastell is Professor of Bone Metabolism and Director of the Mellanby Centre for Bone Research at the University of Sheffield. He is an internationally recognized expert on the use of bone turnover markers and the development of treatment for osteoporosis. Professor Eastell, please, now over to you.
Thank you, Dominique, and hello, everybody. Thank you for joining this. And this afternoon, I'd like to speak to you about bone turnover markers for monitoring the treatment of osteoporosis. So I'll begin by talking about giving you my conflicts of interest shown here. And my topics today are going to be the introduction to bone turnover markers. And so I'll tell you about what we currently think in relation to the choice, and then talk about monitoring treatment for osteoporosis. And we're going to focus particularly on this because the issue of adherence is a really important one, and we think this is an area where bone markers can be really quite helpful. I'll then talk about the identification of response in the individual and talk about the statistics that we use to try and identify responders. And at the very end, I'll talk a little bit about how we monitor the offset of treatment. So when we give people a drug holiday, how do we go about monitoring whether the treatment has worn off or not, and whether it's ready to restart the bisphosphonate. So as I go along, I'll illustrate some of the points that I'm making with case histories. So here's my first case history, which is a 70-year-old woman who had osteopenia diagnosed on spinal radiographs. She was being treated with alendronate at the licensed dose, along with calcium and vitamin D. And the T-score would meet the criteria for osteoporosis with a value of -3 at the total hip and lumbar spine. And at the baseline, we measured two bone turnover markers. We measured CTX and P1NP. CTX is a marker of bone resorption, and it was quite high at 500, and P1NP, a marker of bone formation, about 60. And then after 6 months on treatment, the CTX decreased down to 120 and the P1NP down to 20. So the question that we'll be asking is she responding as expected to the treatment or not? And I'll come back to that once I've given some background information. So let's just say a little bit about the bone turnover markers that we have to choose from. So some of the markers relate to the work of the osteoclast. These are referred to as the resorption markers. Most of them are degradation products of type 1 collagen, although there is an enzyme that can also be used for this purpose. With bone formation, the osteoblast produces a number of proteins which can be measured in the circulation, including osteocalcin, P1NP, and bone alkaline phosphatase. Now, although there are several choices for bone turnover markers, the IOF and IFCC has proposed that we consider CTX and P1NP as the reference markers. This doesn't mean the other markers are of no value. It just means that when we're doing our research, we should always make sure we do these two so that we have data on something. Now, one of the key facts about measuring bone turnover markers is that we need to appreciate the sources of variability. Some people claim that bone markers aren't so helpful because they do change from day to day, but that's part of our normal physiology. And so we need to know about what the factors are that cause these changes. So in relation to controllable sources of variability, then the circadian variation, or the variation through the day, means that the bone resorption markers, like CTX, decrease a lot from the morning to the afternoon. So the values in the afternoon are very low. And also after a meal, such as after breakfast, these markers decrease by a lot, by 20 to 30%. So we recommend, when we're measuring a bone resorption marker like CTX, that the sample is taken first thing in the morning with the patient fasting. Then when it comes to uncontrollable factors, there are several of these, but the one I'm going to point out to you particularly is the effect of a fracture, since we're really talking about the use of bone markers in the setting of osteoporosis. And when a patient has a fracture, the bigger the fracture, the greater the increase in the bone markers. They tend to peak around about 3 months after the fracture, and by about a year, they're back to baseline. But it is important to ask about the history of a recent fracture when you're interpreting bone turnover markers. Now, what are the uses of bone markers? And over the years, a number of uses are being proposed. It's been thought that they might be useful for risk assessment. For example, high bone turnover in a postmenopausal woman is associated with rapid bone loss and also with an increased risk of fracturing. The high bone turnover may indicate that there's secondary osteoporosis present. But although these are all being proposed, they haven't been sufficiently well supported by research to translate into clinical practice. On the treatment side, it's been proposed that bone markers could be helpful in selection of treatment, such that if a high bone turnover was found, the patient might be more likely to respond to anti-resorptive treatment. And that is true, that has been shown by research, but it's also true that anabolic drugs are most effective in people with higher turnover. So the selection hasn't proven to be so useful. But where markers have proven to be really useful is in monitoring response and by identification of poor adherence. And this is going to be the main topic that I'm going to speak about today, although I will speak about the monitoring of offset of effect when we take a drug holiday. So the use of the bone turnover markers for monitoring treatment. And I'm just going to talk today about anti-resorptive treatment and specifically about bisphosphonates. Now, a few years ago, we designed a study called the TRIO study, which was designed specifically to answer questions about monitoring. And so in this trial, we studied postmenopausal women with osteoporosis who were receiving, who were randomized to receive ibandronate, alendronate, and risedronate at the licensed doses over a 2-year period. And they were postmenopausal women, 172, who had osteoporosis. And we did 2 things that made this into a special study that helps us with monitoring. The first thing was that we estimated for both bone density and for bone markers the least significant change in all the patients. And so by making measurements on treatment at 12 and 13 weeks, we allowed us to estimate for 5 bone turnover markers and several bone density sites the least significant change, which I'll explain in just a moment. Also, we recruited concurrently a group of premenopausal women, 226 of them, who had reached maturity. And we think that skeletal maturity occurs somewhere between 33 and 40 years. And this allowed us to have a strong reference range against which we could compare the postmenopausal women with osteoporosis. So if I show you the results at baseline, this shows what happens to the bone turnover marker serum CTX at baseline in these women with osteoporosis from the TRIO study. And I want to make 2 important observations. One is that we're showing here the reference range for healthy young women in blue. And I want to show you that only about 20% of women with osteoporosis are above that. Now, of course, these women who are above that are more likely to have rapid bone loss and to fracture, but it's only 20%, so it's no good for a diagnostic test for osteoporosis. But the remainder of women are almost all in the upper half of normal. There's almost nobody in the lower half. Now, you might be wondering why I'm using the word half, because the red line doesn't seem halfway between the upper and the lower blue lines. And that's because bone markers have a skewed distribution. And in healthy young women, half of the results are below the red line and half are above. So you can see what's special about women with osteoporosis is that very, very few fall below the red line. And I'll come back to that a little bit later on when I'm defining what a response is. So these women will receive one of the 3 oral bisphosphonates, and here I'm showing the results from alendronate. And if we focus on the orange line, which is the CTX, we can see that within a week of taking the alendronate, there's a reduction of about 50%. And by 12 weeks, there's a reduction of over 80% in the CTX. So this is a very, very large change. And you'll notice also that the error bars around the CTX are less than they are for the other marker, NTX, which is why we chose the CTX as our principal marker. That's for resorption. Now, if you look in the same kind of slide, I'll show you the effects on bone formation markers. And here we have the bone formation markers, bone alkaline phosphatase, osteocalcin, and P1NP. And there's a couple of things that you might want to notice here. The first is that for the first 4 weeks, there are no change in the bone formation marker. And that's because bone formation is coupled to resorption, and it follows on from resorption. The second thing is that the maximum decrease has almost occurred by 12 weeks. And that the maximum decrease for P1NP is greater than for osteocalcin and bone alkaline phosphatase, again supporting the use in osteoporosis of P1NP as a reference marker. Now, you may be asking, do these changes in bone turnover have anything to do with the outcomes in these patients? So recently, we conducted a study where we tried to gather all the information about bone turnover markers from the major fracture trials and relate the changes in markers to the fracture risk reduction. And I'm showing here the vertebral fracture risk reduction, and the circles all represent individual studies. The bigger the circle, the larger the study. And you can see that the greater the reduction in either bone alkaline phosphatase or P1NP, the greater the reduction in vertebral fracture risk. So the bone marker change does seem to relate to the fracture risk reduction. So I've talked to you about groups of women, and now we need to talk about individual women and how we can use bone turnover markers. So the critical thing is to describe the statistical approach to looking at individual people. And the key thing we use is least significant change, LSC. If you come from a clinical chemistry background, you might have come across the term reference change value, which is the same thing. But we usually use least significant change in the world of bone metabolism. And this has been used for a long time in relation to bone density. And I'm showing the results here of lumbar spine bone density over a 2-year period, where you can see that in the control group, the blue line, there was no change in bone density. Whereas in the red line, you can see the increase in spine BMD of about 6% or so over the 96-week period. And on this graph, I've shown the dotted line, which is the least significant change, which is about 4% in this particular study for lumbar spine bone density. So the average woman at 48 weeks was around about the least significant change, meaning that about half the people are responders and half the people are not responders. By the end of the 96 weeks, about 2/3 of the women would be responders. If you contrast that with P1NP, one of the bone turnover markers, you can see again that the control group didn't change over the 96-week period in blue, whereas the red group, the group receiving alendronate, did have a decrease, which was maximum around about 12 weeks. And at that time point, more than 80% of the women were showing a response because they were below the least significant change. So I'm showing you here the individual people from the 3 treatment groups, ibandronate, alendronate, and rezidronate. And so the y-axis is showing the percentage change, and the x-axis the 3 individual groups. And the shaded area represents those patients who would be called responders. So you can see the vast number of people here were called responders when we use CTX and a least significant change of 56%. So if you look at the responders for alendronate, it was 98%, and it was only a little bit less for azidronate and ibandronate. Similarly, if we use P1MP, this least significant change is a bit less, 38%, and you can see about the same proportion of people were responders, somewhere between 80 and 94%. So these two approaches, P1MP and CTX, both seem to be quite good at identifying responders by 12 weeks on treatment. Now, not everybody is able to get a measurement before the treatment is started. And sometimes the patient presents to us when they're already on treatment. So a second approach that we can use to identify a responder is shown here. If we look at the CTX in the left-hand panel, you can see from the box and whisker plot before we start the treatment that many patients are either above normal or in the lower or in the upper half of normal, and almost nobody is below the horizontal line that's at about 280. Whereas if you look at the 12-week or the 48-week, almost everybody who's been given alendronate falls below the horizontal line. So this indicates that the vast majority of patients are responding when we give alendronate and we look at the CTX level. Similarly, when we look at the P1MP, -1, when nobody's been treated, the levels are all above the average for young women, whereas when we give the treatment, almost everybody is below that value. So if we use this way to identify responders, with the CTX, about 96% of women are below that threshold of 280 for CTX, and about, for the P1MP, the threshold, which is about 35 or thereabouts, more than 80% were responders. So this is an alternative method for getting the target. So when we summarize this as the approach we should take, we can have two targets for treatment. One is to exceed the least significant change, which is a statistical approach, and it relates to the fact that large reductions in bone turnover markers are associated with a low fracture risk, as I've shown you. It does require a bone turnover marker to be taken before treatment as well as during, but the initial value might be of some use. And the P1MP, for example, might be reduced by 10 micrograms per litre. And I'm giving a number now rather than a percent, because we found that when we've translated this approach into clinical practice, the general practitioners really prefer numbers rather than percentages. On the right, I show that below the mean value for healthy young women is our second target. And that's because a low bone turnover marker is linked to low rates of bone loss and low fracture risk. And it only requires a bone turnover marker to be measured on treatment. So here, an example of how you might interpret this is that if the P1MP was below 35 micrograms per litre, the person would have reached their target. So having shown you about the TRIO study, then I want to mention to you about the problem of adherence or non-adherence in relation to osteoporosis medication. So as I'm sure you all know, that bisphosphonates are considered a first-line treatment for osteoporosis, and mostly we use oral bisphosphonates. And the adherence to these oral bisphosphonates is often 50% or below after 1 year. And so this is a problem because the low adherence results in a lack of efficacy and a reduction in their fracture risk. So this is a major problem. It's of course true for many other medications, but it's certainly true for our medications. And so the International Osteoporosis Foundation and the ECTS, the European Calcified Tissue Society, got a group together a few years ago, and we sat down to think of a way in which we might be able to identify adherence in clinical practice and take action. And this article was published by Diaz-Perez and colleagues 2 years ago. And this is the algorithm that we came up with. We thought that as a woman was to start her course of treatment, we might measure bone turnover markers. We could measure P1MP or CTX or both, and then start the treatment. And after 3 months or so, we could measure the bone turnover marker again. And if it exceeded the least significant change, we would say continue the treatment. And if it didn't exceed the least significant change, then we need to reassess. So let me show you in more detail what this might mean in practice. So this is an algorithm that we've taken into our general practice in Sheffield and asked our GPs to do when they start patients on oral bisphosphonates. And they seem to have accepted this approach quite well. So when they make a decision to treat, they obtain a baseline bone turnover markers, do a compliance check verbally after a month, and then after 6 months, check the P1NP or the CTX. It turns out that our GPs prefer P1NP because they don't have to take it at any particular time of day. And then once they have the value at 6 months, they have to interpret it. And so the interpretation of a P1NP is that the decrease has to go down by more than 10 micrograms per liter and to a level of less than 35 micrograms per liter. So we give them those two simple rules and they can implement them in their patients. The alternative is if they'd use CTX, the decrease would have to be 100 nanograms per liter to a value below 280. So that's the simple approach that we take. And so what do we do when there isn't a good response? So they obtain the bone turnover marker, they find that the bone turnover is not suppressed, so they have to reassess. Now, by far the commonest reason for poor response would be poor adherence. And so they would ask the patient, are they taking the tablets correctly? And a lot of the time, the patient isn't. Even though there's been an adherence check, it's often not until we do the bone turnover marker that the patient comes clean and admits that they've not been adhering properly to the instructions. So if that's the case, then we ask the patient to take the medicine correctly and then come back in 3 months' time and we check the bone marker again. If it turns out that they're still not responding, then it could be something else. It could be that they have some underlying form of secondary osteoporosis that we haven't identified. And over the years, I've seen patients who become thyrotoxic or develop celiac disease that's been perhaps missed the first time round. And this is the reason for them not responding. So it's useful to look again for secondary osteoporosis. And if it's neither of these things, if it's neither poor adherence nor secondary osteoporosis, it may just be that that particular patient doesn't respond to an oral bisphosphonates. That does seem to happen just occasionally, in which case they may well benefit from a parenteral therapy. So let me just show you what happened when we audited our results from the general practitioners. I'm showing you here the change in the P1NP from baseline to 6 months in the patients receiving the bisphosphonates, just showing you what happened when it was a good response. And that's the black line. The black line shows you that from baseline to 6 months, they've decreased by more than 10 units in P1NP, and they've gone below the broken line, which shows 35 micrograms per liter. So the black ones show that they've responded and reached the target. The red ones show that they've responded and haven't reached the target. The yellow ones show that they were low to begin with and stayed low. The broken line shows you that they haven't responded, and these are people we want to pick up and correct them. And finally, one patient, the green line, actually had an increase, and that's because they had a fracture. So we have lots of different stories to tell you here about what happens when you introduce these markers into clinical practice. So to go back to our case report, then we've noticed that she has decreased her CTX from 500 down to 120. She only had to decrease by 100, and she's decreased by a lot more than that, 380. And so that's really good response. And she's below the healthy young mean, which is 280. So we're quite happy that she's responded with CTX, and with P1NP, she's decreased from 60 down to 20. She had to get below 35, and she had to go down by more than 10. So she's met her response and her target. Good. Just one other comment while we're talking about what we do with patients is that sometimes while we're monitoring patients, they have a fracture, or we've measured their bone density and they've had a decrease. And then the question is, what do we do? Well, bone turnover can be helpful there, because if it's not suppressed, we might go along and give them a parenteral treatment like zledronate or denosumab. And if the bone turnover marker is suppressed, we might go ahead and give them an anabolic treatment like teriparatide. So I've spoken to you now about how we might use bone turnover markers for monitoring therapy. Let's talk a little bit about offset. Now, the offset story came about because it was noticed that some patients, while getting long-term bisphosphonates, might develop an atypical femur fracture, which is what I'm showing you on these radiographs here. And there's still a lot of controversy just what is the chicken and egg here. But if we assume that there is an association and that bisphosphonates, the longer you give them, the more likely you are to cause an atypical femur fracture, then it may be reasonable to give a drug holiday after giving the oral bisphosphonate for 5 years. And the reason why we can think about this is that bisphosphonates are special in that when we give the bisphosphonate, the bone density goes up, I'm showing you here, over 4 years with alendronate. And then when we stop the alendronate, the bone turnover goes down a bit, but it doesn't get back to baseline. And so this very special phenomenon we see with bisphosphonate treatment means that the bisphosphonates go to the bone and have an effect for years after they're stopped. So we've seen that with bone density there. We see it with bone turnover here. So here, when the patients are given alendronate for 2, 4, or 6 years, you can see over 6 years you get continuous suppression of the bone resorption marker NTX. Whereas after 4 years, if you stop, you get partial resolution, but it's not complete resolution. So this continuous effect after stopping seems to happen with alendronate. And we just recently published the trio offset study where we took those same women that I showed you earlier while they were being given 2 years of bisphosphonate during the trio on treatment period. We then studied those patients who stopped. And you can see that for all 3 oral bisphosphonates, there's some offset of effect, but it's not back to baseline, whether you use CTX or P1NP. So all 3 of these commonly used oral bisphosphonates do have persistent effects even after stopping. So how do we manage this in practice? Well, what we might do here is that when we're making the decision to stop treatment at the 5-year time point, we might measure a bone marker and then repeat that 12 months later. And if the bone marker has gone up beyond the least significant change and to above the threshold, then we might feel that the response has been reversed and therefore the patient should go back onto treatment. Whereas if the bone marker remains suppressed and hasn't increased significantly, the patient can stay off treatment. So this is just one way that we're proposing we might use bone markers, but it's not fully proven yet. So if you take the patient that we were talking about earlier, when she got to 5 years or 60 months of treatment, and she was 120 with the CTX, 12 months later, when the bone resorption marker was measured, it was 400. So that's a significant increase, and it's above the threshold of 280. So she would need to restart treatment. And similarly, if we had measured P1NP, she's gone up from 20 up to 40. So she's exceeded the least significant change of 10, and she's gone above 35. So she needs to restart treatment according to this algorithm. So let me just give you a couple of case examples of offset of treatment. So here's an 87-year-old woman coming to the clinic at the follow-up. And both of these cases, by the way, they're patients that we just saw in our own clinic in the last month. And so I'm not making these up. And so this was an 87-year-old woman with osteoporosis, and she'd had multiple fractures, including vertebral fractures of L3 and L4. She had been on alendronate treatment for 10 years and then stopped in 2017. So that's 2 years ago. And now she's just taking calcium and vitamin D. We usually do an imaging of the spine when patients come to our clinic who have vertebral fractures, and we did that and found that she had a new fracture at L2, which was confirmed by radiographs. So what are we going to do now? So what we did do is we obtained a P1NP result. The P1NP is now 140 micrograms per liter, so it's really quite high. And so we could give teriparatide, but we just feel that perhaps an anti-resorptive drug, given the high turnover, might be very effective. So we gave her zeledronate. So that was our choice. So even though she was on alendronate for 10 years, because she's had a 2-year window, we feel it's safe, relatively safe to go back onto an anti-resorptive. Here's my second case. This is a 78-year-old woman, and she'd had osteoporosis, but no fractures. One of her risk factors for having fractures in the future is that she has Parkinson's disease. She has been given alendronate in the past and zoledronate, and again has had about 9 years of treatment altogether, so that's quite a lot. And you can see on the right there that her bone density did respond to that treatment, and it's only really over the last couple of years that the bone density has been going down. So by the end of the 9 years of bisphosphonates, she'd reached a T-score of about -2.9 for the spine and -2.3 for the hip, but she's had 5% bone loss. So what are we going to do here? So we have measured the bone turnover marker, in this case P1NP, and it's 36. And so would we treat her? Well, it turns out that we do have a previous result of P1NP, and 6 years ago the P1NP was 8 micrograms per liter. So she's gone from 8 to 36. So she's exceeded the least significant change of 10, and she's above 35. So for those two reasons, we thought it was reasonable to restart anti-resorptive treatment, and we gave her another infusion of zoledronate. So that's how we have been using bone turnover markers in the drug holiday setting of managing osteoporosis. So now I'll sum up. So what I hope I've been telling you over the last half hour or so is that bone markers show a large and early response to bisphosphonate therapy. And this makes them particularly useful because it means that a lot of people will respond if they take the medication properly beyond the least significant change. That's one of our criteria for response. And also we're looking to see if they reach the target, which is the below the mean value for a healthy young woman. The response appears to relate to fracture risk reduction, so it's probably a valid surrogate marker. And then when we talk about drug holidays, it looks like the offset of effect of the bisphosphonate can be detected early if we use bone turnover markers. And I've tried to explain to you how we might use that by using these same concepts of least significant change, particularly when it's expressed in absolute numbers, and also by relating to the mean value for healthy young women. So I hope with that, I've provided you with some insight into how we might use bone turnover markers for monitoring osteoporosis. And I'm ready now to take any questions that you have about this work. Thank you.
Thank you very much, Professor Eastell, for your talk and covering the use of bone turnover markers for monitoring treatment and for identifying a response in the individual as well. Thank you for presenting some clinical cases which I'm sure were appreciated by our audience. And now I would like to move on to questions, as we have received a number of them during the presentation. So my first question to you will be, at which interval would you reassess adherence to treatment by measuring bone turnover markers?
Yeah, so typically we often make the first assessment after between 3 and 6 months. The reason for going earlier is that it might motivate the patient more. The reason for going later is if we're using P1NP, it'll be reaching its maximum suppression. And then if we want to check later, because the patient maybe hasn't responded and we've checked their adherence and so forth, we then wait another 3 months before we make the measurement again. Once we're convinced that the patient is responding to our treatment, then I don't normally make a repeat measurement until we do the bone density test at 5 years and we're discussing whether or not to have a drug holiday.
Oh, sorry. Okay, thank you for your answer. I have a second one. If blood tests are too expensive or not reimbursed by health insurance in my country, is it possible to measure only one marker? If yes, which one would you suggest?
Yeah, so this is a really important question, and the cost of bone markers, it differs enormously by country. it often depends on the way in which we pay for our health. So in my clinic in the UK, if we're wanting a bone marker like P1NP, it costs £8 or $11. That's all it costs, and yet in America it would probably cost $120. And so the price really does differ from country to country. So it is an issue in deciding whether you measure one or two, and how often you measure them. And so what you can do to reduce the cost is to measure just one, and you can measure either the CTX or the P1NP. The cost is usually the same for the two of them, for one of them, and so therefore you just choose which is the most convenient to you. The advantage of CTX is that it's a logical one to measure. You're giving an anti-resorptive drug, and so it makes sense to use a resorption marker. And it's more dynamic. It changes earlier and to a greater extent than P1NP. It's just that P1NP doesn't have that effect of feeding or circadian rhythm. And so if you're seeing the patient at lunchtime or the afternoon, you can measure the P1NP and you don't have to worry about this effect of eating. And so in the clinic, in our clinical setting and in the general practice setting, P1NP has become very popular just because it's so convenient not to have to worry about fasting.
Thank you. I have another question. How frequently do you use monitoring by bone resorption markers after the first 3 months?
So when we looked at this, it turned out that there was some equivocal results. When we were in the clinical setting, there was an equivocal result, probably about 1 in 3 patients had either no response or not a very good response, and 2/3 were doing very well. So it's probably about 1/3 of them that we're worried about, and so they're the 1/3 who we speak to about adherence, and then say, make sure you're taking these medicines absolutely correctly, and then they come back 3 months later, and at that point the vast majority will be responding, and it'll just be a small number, perhaps 5% of the total, who are still having problems, and they're the ones who might have secondary osteoporosis, or they may just not be responding to the treatment.
Thank you. I have a slightly different type of question, focusing more on fracture and BTM. Somebody is asking, how could you use BTM, bone turnover markers, to decide what to do after a fracture when all bone turnover markers are increased?
Yeah, so this is obviously a very clinically important question, because there's a lot of encouragement to have fracture liaison services, and so we're often identifying our patients in the few weeks after they've had a fracture. And so at that time, if we measure the bone marker, then it's not as informative as it would be if the patient hadn't had a fracture, and it's going to decrease as the bone marker anyway over time, even if you don't give a treatment. So that makes the whole thing a bit complicated. So what I do in that situation is that I measure a bone resorption marker, because although after a fracture there is an increase in bone resorption markers, it's not as great as it is in the bone formation markers. The bone formation marker P1NP is particularly responsive to a fracture. So when we have studied P1NP after a tibial shaft fracture or an ankle fracture, the levels double or triple. So these are huge changes in the bone marker, and they don't return back to baseline until at least a year after the fracture. So they can cause a big change, whereas the markers like CTX and NTX, they might go up, but only more like 30 or 40%. So that's our solution usually, is if we are wanting to monitor somebody after a fracture, we would give preference to a resorption marker, and the resorption marker tartrate resistant acid phosphatase isn't very responsive to a fracture, so that might be a good one to use to monitor treatment in that setting.
Another question regarding more like the patient. Like, as a patient, can I ask my physician to perform blood tests to reassure me that I'm responding to the treatment?
You can certainly have the patient ask the doctor. The availability of bone markers, it ought to be very good, because the same analysis machines that measure thyroid hormones and other hormones are often able to measure bone turnover markers. And so the machines have the availability of measuring the bone markers. It's just that you have to ask the laboratory to set them up for you. So the issue might become if the patient goes to the doctor and the local laboratory hasn't set up the marker assay, then the sample might have to go to a lab somewhere else. So it's just the doctor might have to do a little bit of investigation as to which lab will do the measurement. But there's no reason why in the modern world why most people wouldn't have access to a bone marker somewhere.
Yeah, I have another question regarding bone turnover marker and anabolic agents. What about their response of BTM to anabolic agents?
Oh my gosh, so that's a really good question. And when I was preparing my talk, I had a whole section on anabolic treatment, but I thought I better cut it out, otherwise I wouldn't have any time for questions. And so, but in our experience with anabolic therapy, and most of my experience is with teriparatide, because that's the anabolic therapy that's licensed in the UK, then the bone markers are really useful. And the one that we use the most is P1NP, because that's the one that's the most responsive to teriparatide treatment. Within just a few days of giving teriparatide, it goes up. And by a month, it usually doubles on average. But we typically monitor, or in my own clinic, I monitor at 1, 3, and 6 months. And it's so good to be able to give the patient the information that they've responded really well to this treatment, because of course it's a nuisance to be having to give daily injections. And sometimes the patient might feel a bit nauseated with the treatment. So it's very encouraging when the patient knows that they're having a good biochemical response. And so I find it very useful to make that measurement at 1, 3, and 6 months. And then maybe at 6 months or a year, I'll get my first bone density test. But no, certainly bone markers are really useful then during treatment. And then, of course, after treatment, once we give an anti-resorptive drug, we can make sure the anti-resorptive drug is reducing the bone turnover back to low levels like it should do after the anabolic treatment stopped. So yes, it's a key part for me of monitoring anabolic therapy.
Yeah, I have another question regarding CTX and P1P assay. If these assays are not available in my country, which other markers would you recommend to follow over the treatment period?
Yeah. So this is an issue because CTX and P1NP they're available in most European countries, but in the USA, the P1NP assay by the analyzer hasn't yet been approved, and so it's not so accessible in that country. So the other bone formation markers which perform pretty well are osteocalcin and bone alkaline phosphatase. The only drawback to osteocalcin is that you have to be just a little bit more careful with it, in the sense that the sample, if you hemolyze the sample, the result is not valid. So you have to be a little bit more careful. The bone alkaline phosphatase isn't quite as responsive as the osteocalcin, but it is a robust assay. So these are two definite alternatives. And then on the side of the resorption, if the CTX isn't available, many labs might have a urine NTX assay which is available. And if you do the urine NTX, that's a second morning void urine. And when you send it to the lab, you have to get the NTX and the creatinine measured, because the NTX is given as a ratio to the creatinine.
And I have, I think, a last question. Is somebody is mentioning that this approach is great because many patients are frustrated that they don't feel the effect of the treatment. Do you find that patients appreciate that something is happening with their bones when you share their markers?
Yep. So it's very commonly the case that the patient, when they come into the consulting room, and you're asking them how they're getting on, and they tell you about what a nuisance it is to take this medicine once a week, and how sometimes they get a bit of stomach ache, and do they really have to take it for the next few years? And then I tell them, that's all very well, but by the way, you've had a really good response, and the markers are doing just what they should do, and they're showing that it's having just what we want. And amazingly, they say, well, actually, all those things I mentioned, I won't worry about them. because I'm so pleased about the fact that the treatment's working. So at a personal level, it seems to really have a positive effect. The mention that they're having an objective response to the treatment. It's been hard to show that scientifically, because doing experiments to test that are just so hard. And I've tried to design studies, but it's really hard to test this experimentally. But certainly in my anecdotal clinical experience, patients really do benefit from knowing that the drug is working.
Thank you. So now we are concluding our Q&A session because we are running out of time. I would like to thank you very much for your participation, and we hope that you enjoyed this session. We will post recording of the webinar on the IOF website. You will be prompted to fill in a survey immediately after this webinar. We would appreciate your input and comments as we continue to try to deliver the webinars that meet our needs. Last but not least, I would like to warmly thank Roche, which made this webinar possible through the support. If you have any questions or comments, please do not hesitate to send an email to info@iofbonehealth.org. Thank you again, Professor Eastell, for your time, and I wish you all a nice day or a nice evening. Goodbye.